Dr. Heidi Hanson is the group leader of the Biostatistics and Multiscale Systems team within the Advanced Computing for Health Sciences Division at Oak Ridge National Laboratory. Dr. Hanson comes to ORNL from the University of Utah, where she is a demographer and life course epidemiologist with experience developing methods for population-based risk prediction. She investigates the genetic and environmental influences on health throughout the life course, focused on the discovery sphere of translational research. Please welcome Dr. Heidi Hanson.
Thank you for the introduction. So I am just a new transplant to ORNL. I come from Utah, and a lot of the results that I'll be presenting today are from my past work in Utah. Just to give you a little bit of background on my theoretical perspective and the way that I'm thinking about these questions. I am coming from a department of surgery where a lot of the focus was based on precision medicine. And a lot of precision medicine is based on omics and genomics. However, for many of the, many of the complex diseases or chronic diseases, environment plays a very big role. And so a lot of my research has been focused on how can we start thinking about bringing environment into what clinicians are thinking about when they are recommending health interventions and thinking about precision medicine. And then also, how can we take the information that we get from these types of studies and apply it to climate change types of questions so that we can activate political movement against some of the most egregious health disparities and exposures. So just to give you a little background, and I'm sure you went a little over this in the last presentation, so I won't go into it in great detail, but changes in climate are projected to affect air quality across the US, and these changes are also expected to affect mortality as well. Now, what I want to kind of point out is that many of the mortality projections are based on older adults. So among adults 30 to 99, you see projections among adults 50 to 99, and you also see the projections only calculating in diseases that affect older adults. So lung cancer, heart disease, and there's very good reason for this. There's just a wealth of evidence that air pollution and air quality affect these diseases. But what I'd like to focus on a little bit more today is other diseases that aren't thought about as much, and thinking about how climate change going forward might affect the population in ways that we haven't projected yet. And yes, I apologize. So the top line is the projection considering no reduced anthropogenic emissions, and the bottom line is if we do reduce emissions. And this is from a paper that was just recently published in the Journal for American Association, or JAMA. So as I talked about, a lot of my research is coming from Utah. And so I'm going to focus on many different diseases that aren't often considered in what the projections are. Sorry, I'm actually going to focus on two diseases, but there's a lot of research coming out of Utah that crosses many diseases. So the diseases highlighted in red are the ones that we actually the studies were done in Utah. So this is just kind of a summary of evidence out there of what are the actual effects of air emissions or pollutants on health. And you can see that it is far-reaching. We see children are affected, reproductive systems and reproductive intent is affected, heart disease, brain, skin, pancreas, and bone, and then more commonly cited are lung and heart. And you see that there are quite a few diseases here, and air pollution really affects the health of an individual. So the two diseases that I will actually be focusing on are cancer, and I'm going to expand it from not only cancer mortality, but complications after cancer diagnosis and treatment, and then also spontaneous pregnancy loss in my presentation. So why Utah? It's not only just a sample of convenience. I'm not picking Utah because I'm from Utah, but there is actually quite a not necessarily unique, but interesting air pollution events happen within Utah. So 80% of the population lives in what's called the Wasatch Front, and that is the map that's highlighted on the right side. You can see this is during what's called an inversion day. So many of the valleys in Utah are surrounded by mountains, and you can see this in the picture that is right here. This is Salt Lake Valley. A large percentage of the population lives here. These are the mountainous regions surrounding it. And what happens is on really cold days, cold air caps the valley and air pollution is trapped below that air cap. And so air pollution levels get quite high during these inversion days. So if you look at the annual average of air pollution in Utah, you're going to see we look pretty healthy, because on most days we do. But in the wintertime, and now it's happening more during wildfire seasons, we have these inversion events and air becomes trapped within the valley, and we get very high levels of pollution over a short period of time. These traffic cam views are showing what the air pollution looks like on similar or same days across different points in the valley. And you will see that there's quite a bit of geographic variation on what's going on. And so we have both spatial variation and temporal variation in air pollution exposure, which is terrible from the population perspective, but makes for a very nice laboratory to look at the health effects of air pollution on a short-term basis. So this is just another couple of slides to kind of hammer home the idea that we have a lot of spatial and temporal variability. Most of what I'm going to be presenting today is going to focus on this area. This is the Wasatch Front, where most of the population of Utah lives. And you can see also has the heaviest level of air pollution. And these are the maximums for the year 2009 by zip code. And then temporally, again, you'll see overall, if you take the average PM 2.5 exposure in a year, we're going to look pretty good. But there are these days where there are very heavy air pollution exposure levels due to that inversion effect. And I've already mentioned that most of the population lives within this segment that we'll be focusing on for most of the day today. The other part that makes research in Utah about air pollution quite unique and very valuable is a database called the Utah Population Database. So the Utah Population Database began actually in the late 1970s, early 1980s by a group of demographers at the University of Utah. And at that time, they started to collect a lot of data on family history information for individuals. So they were able to get this information from the Utah Historical Society, and it's been supplemented with information from Ancestry. So we're able to build these very large pedigrees and look at family history of disease. Well, being demographers, they were interested in more than just family history of disease. There was a legislative mandate made that required all administrative data to be sent to the Utah Population Database to be linked to these pedigrees. So this includes birth certificates going back to 1905, from 1905 to the present, death certificates during the same time period, which allows us to see where people are born and die. And then in addition to that information being linked to these family histories for the entire state of Utah, we have information from the Utah Cancer Registry, which begins in 1966 in Utah. So that gives us a very rich resource for looking at an entire population's cancer risk. They have information on healthcare claims from the University of Utah and Intermountain Healthcare, which are the two biggest carriers in the state of Utah. They cover 85% of population. That's outpatient, inpatient records, ambulatory surgery records. And all of that information is linked to the demographic records that I was speaking about before. They also have statewide admissions for inpatient records, emergency department records, and those are linked as well. So we see essentially a statewide health trajectory of an individual from 1996 going forward. And then it's linked to voter registration records so that we can see where individuals are moving across their life course, driver's license records, again, so we can see where individuals are moving across the life course, so that what you can actually do is have a data set that's very rich and allows you to see where individuals are residing, what their exposures might be as early as birth, and then look at their health history later on in life. As you imagine, the data security here is a very, very big thing. So it takes quite a bit of approvals and a long process to get approval to use this data. And the data are kept on the VMs at the University of Utah. But if you are able to go through the process, it leads to a very rich resource for investigating environmental exposures and genetic factors that lead to disease all throughout the life course. So the first study that I'm going to present to you is looking at maternal fetal health. So essentially air pollution and pregnancy loss. And this is generally a very difficult thing to study. And there's certainly going to be bias in the results that I am going to show you today. And we'll discuss that. The way that we're getting information about the pregnancy loss is from the administrative claims records. So essentially, the pregnancy loss must have occurred during a time period where an individual would show or report to the doctor because of the pregnancy loss. So there's bias. We're not capturing miscarriages that happen very early on, or miscarriages that would result in an individual not going to see their practitioner after the miscarriage. But we are able to capture data for the entire Wasatch Front in a very, very systematic way. So we're not seeing biases based on which health system they're reporting to. And we are able to take advantage of the Utah environment where we have periods of very high exposure for short periods of time. And that's what you're seeing right here with this calendar. So these are monthly levels. Sorry, these are actually daily levels of PM 2.5 exposure. Green days are good, red days are bad. And you can see that there's quite a bit of temporal variability throughout the entire year. This is January to December. And so what we do, because it's very hard to get to causal statements when you're looking at something like a miscarriage in an administrative health record, but because we have this large temporal and spatial variability in air pollution, we're able to take advantage of something called a case crossover design. And this case crossover design allows us to get as close to a randomized controlled trial as we can with administrative data. Again, causality is not something we can say here, but it's very, very close, where we're comparing an individual to themselves on different days. So we look for an individual's risk for miscarriage on multiple days, and we control for same day of the week because people present, there is selection into when people present to doctors. So we do same day of the week as the actual event happened. So this red day is date of miscarriage. And then we compare the individual to themselves on other dates that they were at risk for a miscarriage. And this allows us to net out anything that we can't capture very well, because anything like socioeconomic status isn't going to change within a month's period of time. Your housing situation hopefully will not change within that short period of time. It's definitely possible, but we're controlling for all of these long-term time constant factors that generally confound the results between air pollution and a health event. And we're using an individual to compare to themselves. And that allows for a more powerful study design than normally. And what we find when we look at records from 2007 to 2015, this study was actually published in 2019. My student at the time is the first author, Claire Leiser, and did a great job on the analysis. And we find that individuals in the Wasatch Front, we had about 1,400 women that had a spontaneous pregnancy loss during that period of time that reported to the hospital. And we find that while there is the pattern of increased pregnancy loss with PM 2.5 exists. It never reaches statistical significance. We do find that a 7-day average in nitrous dioxide exposure increases risk for miscarriage. This was a study, this figure is taken from some of the press that was given to this study after it was released. But you see that the average nitrous dioxide level across the study was 35 micrograms per cubic meter. This is an average day. And the peak level is 145. And we find that a 20 microgram per cubic meter increase is associated with a 16% increase in the risk of miscarriage. And this is a linear association, so it's not a threshold effect. For every 20 micrograms per cubic meter of increase in nitrous dioxide exposure, you see another 16% rise in the risk for miscarriage. So that is the Utah study. There have been findings that have reproduced this association, not in the same exact way. This study takes a bit of a different approach to doing it, but they're also finding similar effects where they see an association between weekly nitrous dioxide levels over gestation and the change in the number of live births. And their assumption is that the miscarriage rate during that period of time increases. And this was reproduced in Boston and Tel Aviv in this study. So there is some evidence for an association between nitrous dioxide and miscarriage risk. There still needs to be more work done on this, but we're definitely seeing it reproduce across different locations and studies. So what does this mean for climate change and also future research? So one of the things that I've been thinking a lot about, and there are some people at Oak Ridge also thinking about these questions. Diksha Ragstoshi is one that is studying this, and Blair Christian is thinking about how this translates in our already known health disparities work. So there are known health disparities in rates of miscarriage and preterm birth and other other birth outcomes among racial and ethnic categories. And so what this is showing you, this is from another study that was done recently published, and it's showing you that exposure to traffic-related or transportation-related air pollution varies between races and ethnicities more than it does for household income, educational attainment, or age. You see quite large differences in exposure. We also know that there are differences in rates of miscarriage and preterm birth and low birth weight babies across races and ethnicities. And if climate change affects certain populations in disparate ways, so climate change is not equally affecting the full population, some of these disparities may increase over time. And this is just to show you that the disparities in pollution exist, and we know that there are health disparities between these things. It's also important to think at the global level. So this is from a paper that was published in 2020 looking at nitrous dioxide. And basically, I don't want to get into the details here, but the takeaway is, again, there are different geographic regions where this type of finding may have larger impact. We know that agriculture is driving nitrous dioxide emissions. And so thinking about ways that we can reduce nitrogen use in agriculture, maybe ways that we can reduce population exposure to nitrous dioxide and hopefully reduce some of these health effects, and that there are definitely global differences. And then this is just to show, based on different climate change projections, that nitrous dioxide is expected to increase over time, meaning, and again, more research needs to be done on this, but there may be increases in miscarriage that disproportionately affect populations that increase over time. So the next thing that I would like to talk about is childhood and young adult health, and I'm talking in the specific context of cancer. So what I'm going to walk you through here is a a figure that my group has put together at Utah. And we put together this figure to kind of talk about air pollution in a different way than people are normally used to thinking about air pollution and cancer risk. So there's quite a large amount of research that shows that air pollution exposure in cancer-free individuals increases the risk for cancer. I would say the evidence is very strong there. And in addition to increasing the risk for cancer, it also increases short-term and long-term clinical inflammation, which has cardiovascular effects, pulmonary effects, and many different other healthcare effects. And we see individuals coming in for asthma, COPD. So air pollution in cancer-free individuals is bad to overall health and also increases risk for cancer. But what is less thought about is how air pollution affects both cancer treatment and how the known cardiopulmonary toxic effects of cancer treatment can interact with air pollution exposure to lead to even more severe health effects in an already vulnerable population. So what my group has been doing is studying the effects of air pollution exposure during pre-cancer treatment, during cancer treatment, and after cancer treatment, so that we can start looking at the individual's health from a more holistic view, not just a single point in time. How does pollution lead to cancer incidence? But not only how does pollution lead to cancer incidence, but response to treatment after cancer has been diagnosed, adverse health effects related to treatment after cancer has been diagnosed, and then survival during the period of cancer, after cancer diagnosis. And so the story here is really much more complex. And again, if we're thinking about this from the lens of health disparities, we know that individuals who are lower socioeconomic status of different racial ethnic minorities generally have higher risk or higher exposure to pollution pre-cancer diagnosis. So if we know pollution leads to cancer, increased risk for cancer, those individuals are already at a detriment because they're at increased risk for cancer due to their air pollution exposure. But then when they return home after cancer diagnosis, they're generally living in the same environment. So if that pollution exposure continues to affect health after diagnosis, they're in a continually increased level of exposure and may have even more adverse health effects related to air pollution exposure over time. So the first results that I'm going to show you, I'm not going to go into details on all of the background and everything, but you're welcome to ask me questions about the study design, is we take the data from the Utah Population Database. Again, we have cancer diagnoses for the entire population from 1966 going forward. We actually trim this down to a smaller subset of individuals because we have very good health records related to visits to the doctor, inpatient records, emergency department records from 1996 going forward. So what we actually do is we trim the cohort to 1989, and we look at pediatric cancer mortality, adolescent and young adult cancer mortality related to increases in PM2.5. And we find that there are increased risk for mortality related to air pollution exposure, PM2.5 exposure. So we do find an increased risk for mortality for pediatric cancer patients with lymphomas. This is neuro cancers, and then lymphoid leukemias. And we see an increase in risk for mortality across all of those cancers for pediatric patients. And then we also see similar effects for adolescent and young adult cancer patients. So we see that there's increased risk for cancers, for multiple different types of cancers and PM2.5 exposure. We do find that for some of these cancers, PM2.5 exposure is protective, which may be a sign that something about the place is leading to this, and something that we may want to consider on further investigations going forward as well. But we do see these significant associations between PM2.5 exposure and increases in cancer mortality. And just to describe this for you, I apologize, I should have done it on the last slide, but what you're looking at is compared to an individual with cancer and lower PM 2.5 exposure, an individual with a 5 microgram per meter cubed increase in PM 2.5 exposure is at approximately a 20% increased risk for cancer mortality at the 10-year post-diagnosis level if they have colorectal cancer. And at 5-year survival levels, they are at approximately a 30% increase in risk if they have colorectal cancer. And this again is a linear effect. So there's not a threshold in what I'm showing you. We're showing that per 5 micrograms per meter cubed, that there is a 30% increased risk in mortality for these individuals. This is when you're looking at a threshold effect. So this is anything that's over 12 micrograms per meter cubed. And you see that there is a definite, this just helps with interpretability. So if you want to say, okay, if any individual with cancer and they're an adolescent and young adult is exposed to greater than 12 micrograms per meter cubed of PM 2.5, they're going to have a 20% increased risk in mortality at 5 years and 10 years. And these are significant. And then you see these associations for melanoma, breast, and colon cancer as well. And you see that the results show for all-cause mortality as well. So this is mortality directly related to the cancer, and this is mortality related to some other cause that's not necessarily related to the cancer. And we also see that there is an effect modification by census tract socioeconomic status, which again feeds into the story about health disparities that are related to socio-demographic factors. And we see that individuals who are in the lowest socioeconomic status census tracts are at even more increased risk compared to those who are at higher levels of socioeconomic status. So this is a penalty just for the lowest socioeconomic status. It's not a linear effect, but there's definitely an increased risk on top of the PM 2.5 or the PM 2.5 exposure is even more detrimental in lower socioeconomic status areas than in higher socioeconomic status areas. And not only does the mortality, do the cancer risks, not only does the air pollution affect cancer mortality after diagnosis, but we also see that it's affecting respiratory hospitalizations for childhood cancer survivors. So individuals who are cancer-free in our population, we're able to look at how often they report to the hospital with a respiratory infection on a bad air day. And this is what this dot is right here. It's showing there's no significant increase for cancer-free individuals in the number of reporting days to the hospital for cancer-free individuals. We see cancer survivors with no chemotherapy, so they would not have had the same cardiotoxic effects or pulmonary toxic effects of chemotherapy. We know that chemotherapy can damage the heart and the lungs, making individuals more sensitive to air pollution exposure on bad days. So if they have not been treated with chemotherapy, there's not a significant increase in risk of reporting to the hospital with a respiratory condition. But cancer survivors with chemotherapy, treated with chemotherapy, do have about a 2 times increased risk in reporting to the hospital on a bad air day. And then we also see a similar type of pattern, although not statistically significant, for respiratory infections. So the take-home story from the cancer results is essentially air pollution has adverse effects, not only leading to increased risk for cancer, but also increased risk of mortality and increased risk for other respiratory, and I'm not showing some of the cardiovascular effects that we found, but respiratory and cardiovascular adverse outcomes during and after the treatment period. And this is work that is brand new, and my group and others are working on studying this question in more detail. So what does this mean for what do these findings mean for future research and with the future of climate change? So this is from the article that I referenced early on that was published in JAMA in 2021. These are the projected changes in annual average PM 2.5 concentrations from 2030 to 2095 with different climate change models. And what I want the take home to be from this figure is that there are big differences in how these changes are going to affect the population of the United States. They're not evenly distributed across the United States, but we see very big hotspots of increased PM 2.5, especially across this southern belt region, where they're projected large increases in PM 2.5 exposure over time. And these increases pretty much overlay with what we know to be disparities in cancer incidence as well. So this is a map of cancer incidence rates. And again, I'm focusing on the younger population because these are the populations that often aren't included in projected effects of climate change. But these are the cancer incidence rates by county for all cancer sites for individuals under the age of 50. So they generally fit into that childhood, adolescent, young adult population that I just spoke about. And we do see that where areas that have high levels of PM 2.5 increase over time already have high incidences of childhood and adolescent young adult cancers. And so it's this double hit effect where we already know that there are known disparities. But as climate continues to change going forward, there are going to be populations that may be hit harder by the adverse effects of air pollution and leading to increases in health disparities over time. And these are just different sources of US mortality from PM 2.5. This was a study published in PNAS in 2019. And again, the basic takeaway from this study is there are many different sources. Wildfire is a big source of PM 2.5 exposure and mortality, and that is only projected to increase with climate change, and that's going to affect different populations in different ways. And that we also see that there are large disparities, not only in who's emitting the pollution, but who's actually using the goods that are leading to those emissions. And we know that there's less usage in goods that are leading to the emissions by the populations that are hardest hit by the adverse effects of climate change going forward. And then I would just like to acknowledge a lot of this work has been done by many different people. We've worked in a very collaborative nature and continue to work in a very collaborative nature going forward. I'm very excited to be at Oak Ridge because it allows me to incorporate more input from climate scientists. And I'm excited for the projects that we will be able to have going forward. And thank you for your time, and I will take any questions now.
Oh, thank you very much. That was awesome. We do have one comment from Alexa in the chat.
So in animal production systems, dairy farms have a great record keeping regarding conception, early embryonic death, abortion, stillbirths, etc. While there are obviously a lot of factors that contribute to individuals' farm reproductive stats over the course of a year, it would be interesting to see if this data might correlate in any significant way with human reproductive data. That is absolutely fascinating, and I think that would be a fantastic study, especially because, as I mentioned before, it's very hard to study some of these things, especially miscarriage, because there's selection into the actual events that we see, which means our results may have some bias to them. And it's a bias that we can't really control for statistically very well. So actually looking in animal populations to see if we see similar things would be fantastic and provide even more evidence toward the effect. So that is a fantastic idea. If anyone wants to pursue it, I think it would be great, and it will be something that I will keep in mind as well. And
that Dr. McCourt could help you with that, because she is our new One Health veterinarian. So she's based in Nashville.
Well, I would absolutely love a collaboration on that. So Dr. McCourt, if I will look for you and email you a follow-up email, and perhaps we can chat about possibilities for collaboration going forward. So the next talk is how exactly will climate change lead to worsening air quality? So there are lots of different ways that it is leading to worse air quality, and it's kind of a web of causation, right? So all of the factors that lead to increased air pollution also lead to increased climate change. And we know that without putting some sort of cap or dampening on some of those things that are going on, they're going to be increasing together. So there's causation. Will have more heat events, more severe weather events. Those heat events can lead to changes in air pollution, air mixing, can increase air pollution. In the case of Utah, let's say, some of the extreme cold days or extreme heat days will change our air pollution exposure because of that cap or that inversion event. So we can already see things happening with changes in the way that we normally experience air pollution in our population. But that I would say there are many different ways that it leads to it. And it's not only direct climate change directly leading to increased air pollution, but all of the factors that lead to climate change also are associated with, many of the factors that lead to climate change are also associated with increased air pollution.
I have a question while we're waiting. I guess there's more coming in, but you had listed several body conditions, body systems that are impacted by climate change and by air quality specifically. And one, for example, you mentioned pancreas with insulin resistance. Is that likely a direct result of inhaling bad air, or is it maybe stress related as well, which is still, all related to it? But can you talk about how those were listed?
Yeah, absolutely. So it's really important when you're thinking about the associations between air pollution and health outcomes to think about what are the biological processes that are possibly leading to this. And there are many different biological processes. So you can have the direct effects where there's some sort of biological link to the particle being lodged within the lung, and that leading to some sort of adverse health effects. So particles being lodged in the lung and leading to increased exposures to certain chemicals or whatever the chemical mixture is in that particle, inflammation. And then there are the indirect effects where you can have things like increases in stress, increases in kind of baseline levels of stress for long periods of time. And there are multiple biological processes going on, and the biological processes affect the different health systems differently. So when a researcher is putting together a study, it's very important to think, okay, why do I think this is happening? What are the underlying biological processes that could be leading to this observed association? And kind of trying to tease those out. At an epidemiological level, we can't answer those questions directly, but that's where some of the animal studies come in And there are more biospecimens that we are able to capture that might allow us to look at some of these things from more of a direct effect and get more insight into exactly what's going on. So for example, the University of Utah has been storing cord blood for a long period of time. So we can take cord blood from mothers who have actually given birth, look at biomarkers that might be related to both increased inflammation or other things going on that are related to that air pollution exposure, and determine or investigate what a biological link may be. But there are many different both direct and indirect ways that air pollution exposure can affect health, and how it's affecting certain organs is dependent on what those direct or indirect effects may be.
Awesome, thank you. And I believe there's one from Dr. Gross in the chat.
So there are hosts of other toxic impacts that might be enhanced by climate change. I am not aware of a review. So if you are aware of a review of them, I would love to see that, and would be very, very happy if you sent it my way. I can also take a look at the literature as well, but I think that's a very great comment, and something that I will definitely look into as I do my research going forward.
Thanks, Anna. Dr. Gross, are you aware of a review?
Okay. I wasn't able to unmute before. Thanks, Heidi. That was a great summary. Yeah, I was just going to respond. So there's a NIEHS has been sponsoring committees through the National Academies on a variety of topics. I don't think there's been a workshop specifically on climate change impacts on toxicants, but I need to go back. I haven't been on that committee in a long time. That's one place I would look, but if they haven't, that would be a great thing for you to suggest, Heidi.
Yeah, I agree with you. I actually like that idea quite a bit. And so I will do a little bit more research on whether or not it has been done. And if it hasn't, I will suggest that and potentially reach out to you as well if you're interested.
Well, Heidi, you may not know, but there is an institute that produces what's called the Risk Assessment Information System. That's between UT and RNL, and that's part of the staff report to me.
Okay.
And it's all on chemical and radiological risk, but we don't do anything about climate. It's all based upon EPA sort of guidelines at current. So it's something I think is worth doing. Let's put it that way.
Okay. Yeah, thank you. I did not know. I'm just brand new, a little over a month that I've been here. So I appreciate you letting me know about it, and I'll definitely look into it.
I'll throw a link into the chat on that.
Okay. Thank
Sure.
you.
Yeah.
Awesome. And I think we've used up our time. So thank you so much. You've got two good collaborations now moving forward.
Yeah, that's fantastic. It's the best part about doing presentations. So thank you very much for your interest, and I'm excited to work with you all going forward.